Good morning. Welcome to Bradford Health Services' first continuing education event for 2024. I am Zach Ludwig. I'm the Vice President of Clinical Services and Accreditation for Bradford Health Services. I'll be introducing and closing today's session and also assisting with questions and comments that you'll be sending our way throughout today. You are viewing this presentation in the webinar format, which means that you are seeing the presenter view, but your video and your audio view are turned off. Please use chat and Q&A if you'd like to communicate directly with us during the session. We will have the opportunity to review some of your questions at the end of today's presentation, time permitting. Please note that you will receive a post-session email that will include a link to materials from today's session, including references as well as a copy of the presentation. Today's session is eligible for 3 continuing education contact hours. Bradford Health Services is providing these hours to you at no cost. Your attendance and participation today are being recorded through your login, which is associated with your email. So there is no need to put your information in the chat box, though we are welcoming you here this morning. Nice to see so many people checking in today. After the conclusion of today's presentation, you will also receive an email with a link to an evaluation. The survey link will be open for 30 days from today. You must complete the evaluation in order to receive credit for your participation. After completing the survey, you will receive a certificate in about 1 to 2 weeks via your email. If you attempt to submit the evaluation late, as in after 30 days from today, it will not be accepted, and therefore we will not be able to grant you continuing education credit. So make sure you complete those surveys. In addition to the email link with the evaluation, you will also have the opportunity to complete it directly at the end of today's session, as we will be posting it in the Q&A and chat box if you want to retrieve it there. But if you do not get it from the chat box, you can wait for your email later today. You will get it. And if by chance you don't, please just email us at our events information on our website. If we experience any technical difficulties, which is a very pertinent topic for today, as we do have some weather systems moving through the mid-state where our continuing education facilitator is located. If we get interrupted, we will try to rejoin the session, but if we're unable to do so in a reasonable amount of time, about 5 to 10 minutes, we will have to make alternative accommodations. What that will mean is you will get an email with what the options are. Depending on how far we get through the session before experiencing a technical difficulty, we may be able to offer partial continuing education credit, or alternatively, we will give you information about a reschedule opportunity in the near future. Now that we have all this housekeeping out of the way, I'd like to introduce our session today. We are excited for today's informational session entitled Treating Substance Use Disorders and Eating Disorders. Our presenter is Leslie Playa. She's the executive director of the SAFE Project, a national 501c3 nonprofit dedicating to contributing solutions towards overcoming mental health challenges, substance misuse, and the addiction epidemic in the United States. As SAFE Project's executive director, Leslie provides leadership and guidance to SAFE Project senior directors and program managers on behavioral health, addiction, treatment, prevention, and all other facets of the SAFE's programming to ensure inclusivity, sensitivity, and accurate representation of affected communities. Leslie received her Master's of Education in Community Agency Counseling at the University of Montevallo and a Bachelor of Arts in English Literature and Theater Arts at Birmingham Southern College. She is a licensed professional counselor and a certified eating disorder specialist with 12 years of clinical experience in the treatment of substance use disorder with both nonprofit and for-profit agencies focusing on program development, operations, and community collaboration. Prior to joining the staff at SAFE Project, Leslie was the Director of Clinical Services for a national eating disorder treatment center, and previously was the founding program director of the Recovery Resource Center in Birmingham, Alabama, which focuses on increasing access to treatment for all individuals with substance use disorder, minimizing barriers to treatment, and eliminating the stigma associated with addiction and recovery across Alabama. I hope you enjoyed today's presentation. I will now turn it over to our speaker.
Hey y'all. Good morning. Good morning. I love seeing everyone checking in via the chat. It's kind of distracting me a little bit because I'm seeing people that I know. So thanks so much for joining. I really appreciate it. Okay. Oops. I gotta go backwards. Well, maybe not really. So yeah, Zach did a great job of introducing me. My previous slide said really everything that Zach has already said. Thank you, thank you. So at this point now, I think I might have 13 years of clinical experience. I'm specializing in substance use disorders and eating disorders. I've worked all levels of care for both SUD and ED, except for inpatient for eating disorders as both a clinician and an administrator. I think that's important to mention because, as many of you know, varying levels of care, varying levels of care have different needs associated with it. So it really just kind of depends. Oh, checking in from Baltimore. I love this. Something else to mention is I am a person in long-term recovery that fuels my work. I'm in long-term recovery from substance use and an eating disorder. So that really does frame how I treat individuals, how I see the addiction epidemic, how I see eating disorders. With that, I have no financial disclosures. Let's go back. No financial disclosures or specific affiliations for this presentation. I'm just really grateful to Bradford for asking me to do this. If you all don't know, it is the end of Eating Disorder Awareness Week. So this presentation comes at a perfect time. And something else to mention is just in general how I present. So as I mentioned, I am a person in long-term recovery. So a little bit more about that. That means that I haven't used substances since July 1st of 2007 and have been absent of eating disorder behaviors for probably about 12 or 13 years now. And I think it's really important to name that. But also, I am a white cisgender female in a smaller body. And so that is how I navigate the world. And I also recognize that with that comes specific privileges. And so there will be things that I'm going to talk about today where we have to really like get into the different biases that are out there. And so I know that as a person in recovery, I also have a lot of privilege that comes with that. So just want to own that. Before we dig into the meat of the presentation, I do want to give you a little bit of information about Safe Project. So Safe Project was founded in 2017 after Admiral Sandy and Mary Winnefeld lost their son Jonathan to an opioid overdose. This is a quote from them saying, "Every morning we wake up thinking, how are we going to save another family from going through this?" A little bit about Sandy Winnefeld. He is a four-star admiral. Was the second in the Department of Defense, was the vice chair of the Joint Chiefs. If you know anything about that, especially if you're a West Wing fan, you know that that is a big deal. Top Gun pilot. And I think with that, him and his wife, Mary, who an accountant, worked for big accounting firms. They had no understanding of addiction, no understanding of substance use. And so when Jonathan went to treatment, he came out, they thought what a lot of families that we work with think of, like, oh, okay, everything's fine. We're going to keep it normal, keep going, keep going. And ultimately things did go well for a while. And Jonathan ultimately died on his fourth day of college in a recovery dorm. There was actually naloxone on the shelf, but his roommate didn't know how to use it. So because of that, they founded this nonprofit. Some of the things that we work on, our mission, as Zach said earlier, is to contribute solutions towards overcoming mental health challenges, substance use and misuse, and the addiction epidemic in the United States. Our vision is to save lives impacted by substance use and mental health challenges through overdose response, stigma reduction, full spectrum prevention, access to treatment, and the development of recovery programs. We do that through looking at 6 lines of operation. Sandy is an engineer by training, and so everything is very like systemic and thought out. And many of you who do this work know and understand this, that in these 6 lines, as we call them, if we are contributing in some way to each of those, then maybe we are kind of chipping away at this bigger issue. So public awareness, we do a lot of public awareness campaigns, full spectrum prevention, as I talked about, not just with youth and young adults, but how do we do overdose response and prevention later on? Prescription and medical response. We work with law enforcement and criminal justice, treatment and recovery. We actually have a safe locator, which has treatment options, family support and recovery housing, as well as family outreach and support. We do all of this through 4 specific initiatives: Safe Campuses, which focuses on our collegiate levels, so any sort of colleges, universities, community colleges, technical schools. Safe Communities, which is a big overhaul because everything is a community, but we really look at systemic change there and how do we help specific communities bring in the resources they need that are tailored specifically to them. Safe Workplaces, we go in and help different businesses, different industries. We work a lot with the construction industry to develop programming or develop policies and procedures that really support recovery and support the ability to ask for help on the job. And last but not least, Safe Veterans. As we know, veterans are a pretty vulnerable population. So we do some military wellness programming, some programming for military connected individuals like spouses and family, as well as a military support group every week. Earlier, I did mention youth and young adults. We do have another portfolio called Safe Choices. It actually lives within the Safe Communities portfolio. And that focuses on our youth and young adult body of work there. So a little bit about Safe Project. I could talk for hours on that. You will see my email later on. So if you have any questions or would like to talk to me further about that, I'm happy to answer them. But this is what we're here for today. We are here for this presentation. Okay. So objectives today. Understand biological, psychological, and environmental factors contributing to substance use and eating disorders. Identify warning signs and symptoms of substance use and eating disorders. We are going to correct some stigmatizing language and utilize new preferred terminology, and implements evidence-based practices for treating the purpose and function of substance use disorders and eating disorders. Now, in this presentation, some of this for you may be review. Some of this may be brand new information. Will we receive a copy of the presentation? I will defer to Bradford on that. It's okay with me. I just don't know if you guys typically send it out. But it's fine with me. Yes, perfect. Yes, you will receive a copy of the presentation. Love it. So again, some of you, this may be review. But a lot of this, I want you to be able to think of it in a different light, especially if you have more experience treating one thing over the other. So if you have more experience with substance use disorders than eating disorders, I want to make sure that we all have a good understanding. We're all on the same page as we are learning this information. What you'll also hear throughout this presentation is I will say something like, oh, I'll say similar to, or like with eating disorders, like with substance use. I am not saying that substance use disorders and eating disorders are the same. I'm not. They are very different. What I do want to call out are the similarities. I think what happens is that substance use professionals are really scared when it comes to treating eating disorders. They're like, ah. And eating disorder professionals absolutely have no idea what to do with substance use. It really is not that scary. There are so many more similarities than what you realize. So that's something that I want us to think of today. The other thing too, there's going to be some things in here that's going to challenge you. It's going to challenge how you treat people, how you treat your patients. You may completely disagree. That's okay. I welcome that. So just excited. Let's go. Let's start with some statistics. So 50% of individuals with eating disorders misuse alcohol or illicit substances. That is actually a rate 5 times higher than the general population. Yeah, isn't that crazy to think of? Up to 35% of individuals who misused or were dependent on alcohol or other drugs have also had eating disorders, a rate 11 times greater than the general population. 83% of the phenotype connection between substance use and bulimia was determined by genetic influences. And the most frequently, it says abused, should say misused, substances by individuals with eating disorders include alcohol, laxatives, emetics, diuretics, amphetamines, heroin, and cocaine. Oh, go back, guys. I'm using 2 different screens. I want to just tell y'all that I'm not usually this technologically unsavvy. Okay, well, maybe that's not true. More statistics. Less than 6% of people with eating disorders are medically diagnosed as underweight. So as we are reviewing this information, I really want you to think of these stereotypes that you have in your mind of people who use substances and people with eating disorders, because I think that's where we have many missed opportunities as clinicians, because we have this idea of what somebody looks like, and we're actually completely missing the mark. In a college campus survey, 91% of the women admitted to controlling their weight through dieting. Gay men are 7 times more likely to report binge eating and 12 times more likely to report purging than heterosexual men. Transgender college students report experiencing disordered eating at approximately 4 times the rate of their cisgender classmates. Individuals who are Black, Indigenous, or other people of color are significantly less likely than white people to have been asked by a doctor about eating disorder symptoms. And those individuals also with eating disorders are half as likely to be diagnosed or to receive treatment. A lot of that has to do with stigma. We'll talk about that more later. Okay, classes of substances. We are not going to review the ins and outs of these, but when we talk about substances, I wanted to define what it is that we're mentioning. So when I say substances, we're talking about alcohol, we're talking about caffeine. I'm not calling anybody out, but I will say that I also have my caffeine with me this morning. If you do too, hey, no judgment, but it is listed as a class of substances. So with that, I'm going to take a drink of it. We also have cannabis, hallucinogens, inhalants, opioids, sedatives, hypnotics, and anxiolytics, stimulants. That's going to be any type of stimulant. So whether it's, methamphetamine or some of our prescribed stimulants like Adderall and Vyvanse. Cheers to everybody, y'all. I love it. Tobacco. And then other is a really important one in this circumstance, because other encompasses so many different things. If you are a substance use professional, think of how many times even adolescents will come in that have misused over-the-counter substances. People with eating disorders, especially when they're using things like laxatives or other emetics or diuretics or like over-the-counter diet pills, a lot of times that actually falls into the other category, but it is missed as a substance that someone is using. I love this quote, always have. It's from the American Society of Addiction Medicine, our ASAM friends. Addiction is a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. Prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. Again, I want to level the playing field here. I want to make sure that we're all coming from this. So if you are a substance use professional and you become activated by someone saying, well, why can't they just stop? Okay. I mean, so many of us have heard this. I want to challenge you, if you ever think to yourself when working with somebody or hearing of somebody that has an eating disorder, why don't they just eat? It's very similar. Okay. So if we are willing to have an understanding and grace about one thing, let's make sure that we're having that about another as well. All right, let's look at some contributing factors to substance use disorders. So obviously there's a biological component. Genetics accounts for about 40 to 60% of variability. So we know this. Inherently that can be passed down. I really want to focus on psychological and environmental though. So with psychological factors, it could be anything from trauma, which we know is the root of so much, especially when it comes to any sort of maladaptive coping skill. Great comparison. Why don't they just eat? Yes, absolutely. Yes. This could be if someone has with psychological a learning disability, if someone has been diagnosed with any other mental health concerns like anxiety, depression, if there is ADHD, obsessive compulsive disorder, anything like that, those aspects can sort of lay the groundwork and potential foundation for misusing substances, especially if there are some specific environmental factors. So when we look at environmental factors, you look at how the family interacts with emotions. So are you raised in an environment that is don't talk, don't tell, don't feel, keep it all in, you know, we're not gonna tell any secrets, keep all the secrets in, looking at specific religious or spiritual upbringing, different cultural upbringing, peer pressure is a big one. How does your family look at help-seeking behaviors? Specific political upbringings, like that could have some sort of influence on that as well. If there is witnessed trauma, so obviously this also goes into the psychological aspect as well, but witnessed trauma. So if you have witnessed some sort of domestic violence, also if you grew up in a house where there is a lot of abuse there, also think of natural disasters. I think that's one that we don't always consider, but especially if you're from Alabama or any of the southern states that are prone to tornadoes, you know about natural disasters and their impact, and also some of the states that are prone to hurricanes as well. Okay, so let's look at some contributing factors to eating disorders. So very similar to what we just talked about with substance use, but what I want you to think of are the 3 Ps. So predisposing factors, precipitating factors, and perpetuating factors. Try to say those 3 times fast. It may trip you up. All right, so with predisposing factors, we look at genetic factors. So the heritability of an eating disorder is as high as 70%. And actually, twin studies show higher rates of eating disorders in identical twins as compared to fraternal twins. Children of individuals with eating disorders are up to 11.3 times more likely to develop an eating disorder than the general public. I think that's really important to look at. You also look at temperamental factors. So is there some type of harm avoidance? Is there novelty seeking, perfectionism, some persistence? Let's also look at early interaction with attachment figures. So what does that relationship look like? is there some anxious attachment? Is there, especially if there is an individual in the house who either has a substance use disorder, an eating disorder, or some other mental health concern that maybe prevents them from actually kind of facilitating the secure attachment or any kind of attachment with a child specifically. Then we look at neurochemistry as well. With neurochemistry, we'll talk about this a little bit more, but as we know, anyone that experiences trauma, it can alter different pathways in the brain. And so this is an aspect of it as well. Precipitating factors. So is there dieting behavior, illness, or trauma? So trauma, I think, as everybody knows, that's going to be like the thread for many folks. But specifically thinking of dieting behavior, I had a friend of mine who is a dietitian in town, and she was meeting with she is now seeing a lot of adolescent clients, 9-year-old client who said, I just need to lose weight. 9 years old. Okay. And that dieting behavior is seen so often, whether it's through social media and whether it's through our own homes. And so think of how many times you might say, somebody offers you like, oh, do you want a piece of cake? Oh, I'm just trying to be good today. Okay, I hear that. What does that mean? But also, if a child hears that, they don't necessarily know the nuances around that. Illness can also be a big factor in this, especially if there is an illness that causes restriction or causes like an extreme amount of vomiting. So I'm thinking of, I've had some clients previously where their eating disorder actually started from having mono or having like a prolonged illness. And so there was a loss of appetite. And then on top of that, people said, oh, you look so good because they lost a significant amount of weight. So that can be difficult there. And then perpetuating factors. So we also mentioned this with substance use disorders, emotional, relational, cognitive, and behavioral. So you're looking at kind of what is the emotional payoff for some of this, what's happening relationally, what messages are being sent and reinforced, what behaviors are also being reinforced as well. So what behaviors are you witnessing and what is being reinforced? Okay, so let's talk a little bit about the brain. Get my other screen ready too. Okay. As we know, with brain chemistry, specifically as it relates to addiction, the reward circuitry in the brain drives nearly all of our behaviors. It makes me think of that quote from Legally Blonde. Endorphins make you happy, and happy people don't kill their husbands. If you know the reference, please say so in the chat. But that's something that I think of. Yep. So good. One time I said that, y'all, I need to tell you this. One time I said that to a bunch of people who were younger than I am, and they did not know the reference. And I felt really sad. Felt really sad. What? Like, it's hard? Exactly. Y'all, we're all in this together. I love it. So remember, dopamine is the central neurochemical that activates your reward pleasantry circuitry. It is also the one factor that all addictive substances and behaviors have in common. I just saw that pop up that movie is 23 years old, and wow, way to ruin my morning. Oh my goodness. So remember the thing about dopamine, we talk about dopamine a lot. Dopamine is not a bad thing. It's not a bad thing at all. We are supposed to have it. It's supposed to be in our brains. So each time we do something, have a really great laugh, go for a run or ride your bike or anything that brings you joy, having a piece of cake, having sex, like whatever it is, all of these different things generate dopamine. It creates that dopamine. There's nothing wrong with it. What happens though is what we see with substance use and with eating disorders is that brain chemistry can be altered by that repeated exposure to the dopamine release based on the substance use or behaviors that raise those dopamine levels beyond normal. I love that you guys are loving Legally Blonde. Okay, so a reminder about the pathways that we have in our brains. So the dopamine pathways and serotonin. If any of you have seen the meme, if you can't make your own serotonin, store-bought is fine. Just a good reminder of that. So again, with dopamine pathways function, so reward, some motivation, pleasure, euphoria, motor functioning, so that fine tuning, compulsion, and perseveration. And then with serotonin pathways, we look at mood, memory processing, sleep, and cognition. Yes, I love this brain slide from NIDA. I have used it forever. Please, y'all, take it and use it. It's such a great example, especially if you're working with individuals who think, oh, like I just don't have self-control, or I don't have this or that. And so really understanding what's happening to your brain, I think, is really important. So as we know, the addictions model purports that both eating disorders and substance use disorders are based on chemical dependency with some similar genetic, familial, personality, and sociocultural influences, like we've talked about. And so what we're seeing with this is that there are those neurobiological factors into that, and specifically with that motivation and reward and affect regulation, and behavioral inhibition, those three things together, we see that those substances and the behaviors impact those things, and that's what causes people to continue those behaviors. So when we look at Yes, you will have access to the slides after the presentation. Yes. So when we look at addiction in the brain, we look at neurons. So how the brain's messaging system works. So think of it this way, instead of like electrical circuits on like chips in our phones and things like that, our brains consist of billions of cells called neurons, which are organized into circuits and networks. Each neuron acts as a switch controlling the flow of information. So if a neuron receives enough signals from other neurons connected to it, it fires, sending its own signal onto other neurons in that circuit. So here's an example of that. So when we have dopamine in the brain, we have dopamine and the dopamine receptors there. When the brain wants to send a message, a neuron releases a neurotransmitter into the gap or synapse, excuse me, between it and the next cell. That neurotransmitter crosses the synapse and attaches to receptors on the receiving neuron, like a key into a lock, essentially. This causes changes in the receiving cells. Other molecules called the transporters recycle the neurotransmitters. So essentially, it brings it back into the neuron that released them, which then limits or shuts off the signal between the neurons. So it's released and then it comes back up. And this is what happens when it's a healthy release of dopamine. And I'll explain that in a minute, what I mean by healthy release. What happens, though, is that when someone is using a substance, it interacts with the limbic system in the brain to release that strong feel good, that euphoric feeling, which then floods that person's body and mind, usually with, like I mentioned, that euphoria. And as we know, with the reward circuitry, our brains are going to reward us when we do something that brings us pleasure. So when that happens, that dopamine is released, and the drugs actually interfere with the way the neurons send, receive, and process the signals via the neurotransmitters. So your brain is flooded, and because it's in there, it interferes with the ability to recycle it. So that's why after prolonged use, people will say, like, I don't feel the same high. Well, yeah, your body thinks that it has more dopamine than it does because of the substance that you're using. And so your brain is not creating as much dopamine. And so when people really cut down on their substance use, there's sometimes that crash. It's like, oh, why do I feel so bad? Well, your brain is learning how to create that dopamine again. Luckily, there can be some repair there, but it just takes some time. But that's why sometimes people feel a little bit worse when they first get sober. And so it's altered that chemistry there. And in time and with the absence of substances or the minimization of substances, your brain will recreate that dopamine. With eating disorders, yes, the anhedonia, yes. There's variance in serotonin levels correspond with specific behaviors. So dopamine in particular, that release happens with purging. This also happens with over-exercising. So earlier I mentioned exercise as a good thing. Exercise is a good thing. However, it can be really easy to over-exercise in the name of health. And a lot of times people will say, like, I just am chasing that runner's high, that runner's high. What's hard is that there was some older studies that said that compulsive exercising really is more than 6 hours of exercise a week. That has shifted a little bit. It's different if you have an intention behind it, like if there is a training purpose. It's all about the motivation there. And especially if the message that you have in your brain is, I need to work out to earn specific food, or if I just do one more mile or this, that, and the other, that is going to send a really specific message. With people with anorexia, serotonin is oftentimes, there we go, guys, oftentimes really disconcerting. So the restriction is to suppress any of the feel-good euphoria or anything that is coming up. So the serotonin and the dopamine. So times when I've worked in treatment, I have seen clients where they are so distressed whenever they have food that they actually really like, because it creates that dopamine. And that is actually a panic for them, because it's like, no, 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 this is not supposed to feel good. This is nothing about this is supposed to be good. And so what we have seen is that there is a complete avoidance of that behavior or of that food or of anything that is going to release that dopamine. We also see that binge eating alters the reward circuitry, which reinforces behaviors too. So a lot of times, like what we talked about with just the reward circuitries in general, it's releasing that dopamine. So sugar does this. I think large amounts of food in general can do this. And so it's just reinforcing that behavior because it is meeting a need, right? This is very similar with substances. It is meeting a need, and that's why it's continuing. I will say that in this presentation, we are not going to get into like, is sugar addictive? Is sugar a drug? We're not going to do that. It's a can of worms we're not going to open today. My philosophy about food in general is that all foods fit, and you can have all-inclusive nutrition. You just have to look at your motivations behind it. So before you get into the sugar is bad stuff, I'm going to stop you right there with that. Okay, a little more about what fuels substance use and eating disorders. So genetics, we've talked about. Peer pressure. Again, this, I mean, we could just put social media on there for that. When you see other people using substances or misusing substances, or seeing people dieting, or I'm so fat, or this or that, or whatever someone is saying, that is going to influence your sense of self. It's going to influence what you believe that you may need to do for your own body or own sense of self. Again, a need to relieve emotional discomfort. the need for self-medicating in some way. A lot of this has to do with control too, not only with eating disorders, but with substance use too. When I think of my own story, my substance use was all about control, as was my eating disorder, but for very different reasons, right? And so especially if you have a client that has grown up with a lot of trauma, that's something to consider. Is food is sometimes the only thing that they can control, or the substances. That's the only thing that they can control in those situations. Family conflict, that is a big one, whether it is traumatic or not, especially if there are no conversations around conflict, if there's no resolution to the conflict. Again, going back to what we spoke of earlier, is there any repair that happens? Are there conversations about feelings? Are there conversations about, hey, like, this is what it means to have a disagreement? Like, are we modeling any sort of behavior? Has that person seen that? Exploration. I think that healthy exploration of substances, like, I think it's okay. We have seen that just say no is not effective. Fear mongering is not effective. And so now, am I advocating that everybody goes and tries heroin? No, I'm not. But can we have conversations about healthy exploration? And again, the motivation behind it. Now, with eating disorders, this is tricky because I'm also not advocating for anybody to go and like try purging, like like an exploration. No, this is a sneakier process, so to speak, because with eating disorders, diet culture is just so, it's just permeated through everything, right? And so a lot of times we may be engaging in dieting before we even know it, and then it morphs into an eating disorder. And so, sometimes like it may be beneficial to do an elimination diet, or if you do want to lose weight, like how do you look at that? But making sure that you're not just exploring restriction for the sake of doing it. Transition and life stressors. Sorry, I'm seeing this come up. Excuse me, transition and life stressors. So again, a lot of that is about control. And so if there is a situation that is occurring, especially for kids, but really for anyone, where you really have no say in it, or you're having to do something that you don't necessarily agree with, or let's say there is a loss in some way, loss of job, loss of income of some kind, loss of like core group, like whatever that is a life stressor, right? And so again, we go back to things that we can control, whether it is a substance, whether it is an eating disorder, whether it is binge watching Netflix and not having to like think or address anything. I mean, I think that is something that we need to look at as well. And then again, other mental health issues. We talked about this earlier. So anxiety, depression, obsessive compulsive disorder, and eating disorders, that they sometimes can go hand in hand for people, specifically if there is a like contagion component to it. So I've treated people previously who they truly believed that food prepared by other people was poison. And so that was something that it had to do with intrusive thoughts and had to do with their obsessive compulsive disorder. And so really kind of reconciling some of that as we address the eating disorder behaviors as well. Obviously ADHD and PTSD, as we've talked about trauma before. Okay. Warning signs and symptoms of both eating disorders and substance use disorders. Physical changes. So sometimes you can tell if someone has an eating disorder by their physical appearance. I'm also going to say this later and contradict myself, but I'm just going to own that. So I think if you have seen someone who has significant weight loss or significant gain, that could be an indication that something is up, right? That's what a lot of these warning signs and symptoms are. They should just make your antennas go up, right? Bloodshot eyes. Also with bloodshot eyes, especially individuals who purge, you will also see their parotids right here, if you can see past my earring, like right here. Their faces become swollen due to purging. And not only are the eyes bloodshot, but you can break vessels in your face from purging as well. So you would see like you would see a difference. Like you would notice that somebody's face is swollen. Blackouts. So blackouts are not just limited to substance use. Some people black out during binges. Some people black out during purging cycles. Some people black out during compulsive shopping episodes as well. So if someone is reporting a significant amount of time that they've lost, that's something to pay attention to. Unusual smells. This can be a variety of different things. But this could be related to, are you noticing that someone has poor hygiene? Are you noticing that someone may have a chemical smell? So like, is there some meth use going on? But I think the lack of hygiene one is going to be really important to take note of. Also, like vomit has a smell. Yep. And so sometimes we know that way. Also, changes in skin. As we know, with people who use substances, there can be a change in skin. This also goes to what I said earlier about the blood vessels. So if you notice that somebody has a change in their skin, whether it's the broken blood vessels, you will also see that individuals who are malnourished, their skin becomes really gray at times, no matter what their weight is. If they're not getting that nourishment, their skin their like pallor is just really off. And obviously, if somebody is misusing alcohol to a point where maybe they have like some affected liver disease or something, their skin changes colors. Tremors. So tremors are not just related to withdrawals. They can be, but we've seen people tremor who are malnourished, people tremor after binge purge cycles. And so are you noticing that that something is happening, especially with their hands or with their body in some way? Changes in sleep patterns. So are people sleeping too much, not sleeping enough? As we know with some substances, there is likelihood that people could be up for days. With others, with other behaviors, you could be sleeping a lot. It just depends. And then again, with visible track marks, for those of you who maybe are not as familiar with substance use, when you think of track marks, I think a lot of times people think of them just right here in your arm, but recognizing that people can inject different substances in their hands, in their neck. I've had clients who've used their feet, so different areas that way. So something, again, to just be mindful of. Some additional warning signs and symptoms. So this is specifically related to psychological and behavioral changes. So are there frequent class or work absences or excessive tardiness? Now, I say excessive tardiness. I'm a person who is late a lot, and that is a part of my character. And it is, timeliness is not my spiritual gift. I am working on it. But what you are seeing here with the frequent class or work absences or excessive tardiness, is this a new behavior for them? Are we noticing that maybe their reliability has decreased significantly? So all of these are just antennas going off. Yep. Sudden mood changes. So are they shifting or swinging pretty rapidly? And it's uncharacteristic of how maybe you've perceived them previously. So irritability, aggression, secrecy, a lot of thank you. Secrecy and isolation are two big ones. I think a lot of times, and if you've worked with clients with, I think just working with clients in general, a lot of times that isolation comes in because there is this idea of this only affects me, or I don't want this to affect anyone else. So I'm going to like completely isolate from family, friends, any type of loved ones because I don't want them to be affected. But we all know that their loved ones are already affected by their isolation. And with the secrecy, you know, it's a hackneyed phrase, but I think it's so true. Secrets keep you sick. And I think substance use and eating disorder behaviors, they thrive in secrecy, especially that lack of control piece. If there are so many different things happening in someone's life that is causing this feeling of being out of control, it's this idea of I am keeping this one thing for myself. I've heard this a lot from mothers that I've treated, both with substance use disorders and eating disorders, that it's like, this is the thing that I have for myself that is helping deal with all of the other things, which I can understand why that maladaptive coping skill feels so appealing. Loss of interest in hobbies or activities. So again, things that people have previously enjoyed, and it's just not there anymore. They're not wanting to do that. Depression. Depression and anxiety are difficult ones because I think we have this idea of like chicken and the egg. Am I depressed because I use substances, or do I use substances because I'm depressed? Either one. So just again, like things to be aware of. Financial problems. People who use substances don't do well with finances because they are, this is a generalization, guys, but oftentimes that money is used for the purchase of substances. And so a lot of times there are other areas of life are being neglected. So that's why you will see a lot of weight loss, like especially if somebody's just not eating. Also, people who engage in binge purge cycles will see a significant amount of financial problems too. So if you have, I've said binge purge cycles a couple of different times, but an example would be someone going to 5 different fast food restaurants and getting food, or ordering in amounts of food and putting it on credit cards and things like that. And so that can add up as part of the binge purge cycle. Some of that can be in relationship to hoarding behaviors. That's an interesting question that came up, especially when you look at eating disorders in particular, depending on someone, on some of the like blueprint or groundwork that I talked about earlier, and how someone grew up around food, that may impact hoarding behaviors. So for example, if you have a client who maybe they had a significant amount of neglect as a child, and there was not food in the home, and kind of grew up with a scarcity mindset, oftentimes there can be this hoarding behavior of food, whether they could engage in binge eating because there's no security of if or when that food will go away. I've also had clients who they've hoarded food and have not eaten it because they wanted it to be there just in case. So it really depends there, especially as it relates to hoarding food. And then changes in peer group. So again, this could also go with isolation, but is somebody hanging out with people that they typically don't? Or are they cutting off different people in their lives that previously they were really connected with? So I think that is something to look at as well. Yeah. Okay, so now we're going to look at some types of substances and behaviors. So obviously these are examples and like there are outliers to the examples. So I understand that. But what we commonly see is that individuals who have eating disorder behaviors and substance use, that individuals that use alcohol commonly have eating disorder subgroups with bulimic features. So when I say bulimic features, I'm talking specifically about compensatory behaviors. Compensatory behaviors look like purging. And purging can be through vomiting. It can be through the use of laxatives, any kind of like diuretics in that way. It could also be through exercise. So specifically, if there's that over-exercising component. So specifically here, bulimia nervosa, anorexia nervosa, binge purge type, and OSFED, which is other specified feeding or eating disorder. We'll talk a little bit more about diagnostics later on, but if any of these are unfamiliar to you, OSFED used to be called EDNOS. So eating disorder not otherwise specified. So a lot of times if you have the criteria for some of these, maybe a little bit of bulimia and a little bit of anorexia, a little bit of everything, it could qualify for an OSFED diagnosis. So with binge drinking versus frequency of use, oftentimes what we'll see is that increased binge drinking may be the result of attempts to restrict the alcohol intake. So as we know, binges can come from restriction. So when we look at specifically food, oftentimes people will engage in a binge purge cycle after there's been a long amount of restriction. Think of it even in your own lives. If you are a person who does the whole, like, I'm trying to be good, I'm trying not to eat carbs, I'm trying whatever, and then it all goes to hell on the weekend, right? So like that is actually a form of restriction. It's a form of deprivation. And then, okay, now I'm getting everything that is that I want. And so maybe I'm eating more than I intended on doing if I had actually incorporated this throughout the week. But with alcohol, what we see is that a lot of times, and I think I talk about this in a couple of slides, that binge drinking is associated with the restriction of food also. And as we know, again, if somebody is restricting a substance or food or something like that, it's going to actually reinforce the binging later on. So that restriction, we get into that binge cycle, and then there's this level of shame that happens, and then some time passes, and it reinforces that. Again, as we've talked about before, that alcohol, especially in that binge pattern, is going to be used for emotional regulation, right? Especially if there are some other behaviors going on. And as many of us know, doing this work, a lot of times we're playing whack-a-mole with behaviors, right? And sometimes people will say, well, this behavior is okay because it's not as bad as such and such. Can't tell you how many clients I've heard say, well, I'm just drinking. I'm not shooting dope anymore. Like, yes, this is a fantastic harm reduction technique. And you are drinking to blackout. So like, let's look at that differently. This happens sometimes with different substances and behaviors as well. Yes, Zach, he's with it. because that's going to come up in a couple slides. All right. I want to go to the other. So we talked about this a little bit earlier. So over-the-counter medications, laxatives, diet pills, diuretics. 75% of individuals with eating disorders admit to laxative use. So I've talked about this before, that a lot of times, especially with laxative use and laxative misuse, it does qualify for a substance use disorder diagnosis. Now, what happens is somebody immediately says, well, I can't send, I'm picking on Bradford because it's their webinar. I can't send somebody to Bradford for using laxatives. It's like, yes, you are correct. Absolutely. But are we treating the laxative use in the way that we need to? Yes, it is acutely, it's linked to the eating disorder. I understand that. But this is similar to when people use Adderall as part of the eating disorder. They can still qualify for a substance use disorder diagnosis, but are we looking at the relationship between the two? So, I think with this, because these levels of the levels of laxative use, diet pills, and things like that, a lot of times this relates to the higher levels of perfectionism and the avoidant personality traits. We talked about this a little bit earlier when we were talking about the 3 Ps. And so this again is about that control, right? And so sometimes we will see this. I mean, we can see this with any eating disorder diagnosis, but specifically with any like binge purge type, especially if it's laxative. But again, with things like diet pills, or if somebody is misusing like amphetamines and things like that. We'll talk about amphetamines in just a moment. Okay. Illicit substance use and prescription use. So these are commonly used in eating disorder subgroups with bulimic features. Again, so bulimia nervosa, anorexia, binge purge type, and OSFED. Again, that is other specified feeding or eating disorders. And what we see are amphetamines, opioids, and cannabis. Amphetamines can be used as appetite suppressants in order to aid weight loss. This is really tricky for people who actually do have ADHD and may need those medications, those stimulant medications. It can be really easy to forget to eat. And so sometimes I've had clients who, yes, have been diagnosed with ADHD. And do we need to look at alternative medications than the stimulant medications due to this? Let's see what else. With cannabis specifically, I have had clients who have used cannabis as a means to combat the eating disorder behaviors. This has been an interesting thing. They'll say, I smoke weed so that I can eat. Like, okay, sure, let's talk about that. With that though, what happens is somebody will say, well, I'm smoking weed all day. It's like, okay, so what is that actually doing for you? Again, we're looking at intent behind this. I'm not going to get into like medical marijuana and all that stuff and what have you. And so looking at that as I am using this to combat the eating disorder, but it is also meeting another need. And so that's why we'll talk about this later. The inclusion, the ability to treat and look at things kind of holistically is going to be really important. I saw somebody just mention like anti-diarrheal medications. Those absolutely fit into the other category too, especially if you look at things like loperamide, which a lot of times, I remember having a client who took many Imodium to get an opioid-like high. Yes, that can be a factor as well. Oh no, there we go. Sorry, my screen freaked out on y'all for a minute. Okay. So we've talked about this a little bit already. So there is something called food and alcohol disturbance. The terrible name for it is drunkorexia. This is not in the DSM. Oh, thank you, Zach, for the Imodium info. Food and drunkorexia is not in the DSM, and it has been around for a couple of years. The more appropriate name for it is food and alcohol disturbance, because drunkorexia really sounds quite stigmatizing. So what it is it's a combination of eating disorder behaviors and alcohol use disorder. It's characterized by the replacement of meals with alcohol. People use this term to refer to behaviors including skipping meals, exercising excessively, and purging food to negate the calories consumed from drinking alcohol. So again, that goes a little bit with that idea of earning something. Even when I think of my own personal story, there was a very specific amount of restriction that occurred before I was going to engage in alcohol use, because it amplified the effects. And again, I didn't want the calories associated with it, right? There's no formal diagnosis in the DSM-5 about this. I would, if you have heard of this term before, switch out drunkorexia with food and alcohol disturbance. There have been some various articles about this, especially when it relates to like Self or Health Magazine or things like that, and it's called drunkorexia. But I think if we can just look at this as food and alcohol disturbance, we are again addressing some things that are stigmatizing. I said this in a presentation once. This was probably maybe a year or two ago, and I said drunkorexia, and someone said, God, that sounds so stigmatizing. And later on we'll talk about stigma. And I was like, oh my gosh, you're right. I'm like sitting here perpetuating stigma. And I think just because we've heard a term like colloquially or anecdotally, like doesn't necessarily mean that we have to use it. So let's just use food and alcohol disturbance instead. I am loving that this is new to so many of you. It's fantastic. So furthermore, with food and alcohol disturbance, this leads to higher rates of serious health concerns compared to people who drink and eat an appropriate amount of food beforehand. I'm not saying this in the context of like somebody with an eating disorder, somebody with substance use. You can have tendencies of food and alcohol disturbance actually without having either. So again, this happened. I remember this happening a lot in college. But if individuals are not drinking and eating an appropriate amount of food beforehand, it leads to higher levels of blackouts, potential alcohol poisoning, hypoglycemia, alcohol-related brain damage. And longer term, the risks are pretty significant for alcohol-related health conditions like liver disease, osteoporosis, cardiac problems, diabetes, and dementia. All right, so let's talk about stigma a little bit. So I'm going to open up my chat. Safe space for everybody. I would love if everyone could put in the chat some stereotypes that you hear of people who use substances. You don't have to believe these stereotypes, but when you think of like somebody who uses drugs, what comes to mind? Okay. I'm gonna read some of them out. Selfish, all homeless, poor morals, no willpower, addict, homeless, poverty, out of control, lazy, homeless. Guys, I'm seeing homeless a lot. Why don't they just stop? Uneducated, junkies. Why don't they just stop? Homeless, poor, thug, stealing, mentally ill, crazy, poor self-control, mental illness, dirty, weak, criminals. Wow. Yeah. Okay, guys. Crackhead, poor self-control, pain, trauma, loser, doesn't care. It's a choice. Oof. Homeless, hopeless, poverty, uneducated, nasty, bad parents, don't want to do any better. Man, guys, lay it on me. All right. So let's stop with the substance use stigma. A lot of control it if they wanted to. It's a choice. They could stop if they wanted to. When you think of individuals with eating disorders, what do you think of? Same thing. Put it in there. Weak, sad, out of control, perfectionist, insecure, stuck, lazy, no self-control, shame, just want to be thin, control, white women only. Woo! Yes. White, wealthy, thin females, low self-esteem, sick, choice, conceited, pill popper, self-absorbed, blame the mother, military person. Oh, okay. Privileged white women. Yep. Feeling they're stuck. Poor self-worth. Bitchy. Oh, okay. Yeah. Attention seeking, low self-esteem, want attention, poor self-esteem. Okay. Just want to be skinny. Oh, heard growing up, classy when rich, trashy when poor. Privilege, so much privilege, so much. Go with the trends, peer pressure. Narcissistic, eccentric, unhappy, will grow out of it. Middle class. Okay. All right. Y'all, I thank you for your participation. Okay. Here's what I would love for you all to think of right now. Just take a second. You don't have to put it in the chat. But I just want you to think of, are there ways that with all of that, have you perpetuated stigma with any of your clients? Do you hold any of these beliefs that maybe you didn't realize? Again, you don't have to answer it. I just want you to think about it for a moment. Have you held this in some way? And it's okay. We're learning. We're learning. That's fine. That's fine. But in order to be more effective clinicians, in order for us to be kinder people, I think we have to look at this. So stigma. As it relates to substance use disorder stigma. I love this. This came from SAMHSA. In discussing substance use disorders, words can be powerful when used to inform, clarify, encourage, support, enlighten, and unify. On the other hand, stigmatizing words often discourage, isolate, misinform, shame, and embarrass. Y'all, I might shock you. Maybe not. Some of you will be like, oh, well, this makes sense. Healthcare professionals are the worst sometimes when it comes to perpetuating stigma. We are. Absolutely. Absolutely. Many years ago, I said that to a group of doctors, and it did not, I think, land the way that I wanted it to, but it's true. It's true because as people, we have this idea of what something is supposed to look like. And I actually had a coworker say this to me. It was so helpful in a way that I did not anticipate. And what she said was, I said something about having the experience previously of medical professionals saying, oh, like you don't look like you would have had a substance use disorder, or you don't look like you would have had an eating disorder, which that one is, I can't. And what my coworker said was, you may not look like you've had a substance use disorder, but you do look like somebody in recovery. And some of that is like, we look at, somebody just said this, textbook cookie cutter signs, right? And so a lot of times when you see people who are misusing substances, or if you see somebody misusing substances, a lot of times like the image that's conjured into your mind is not me. But recovery a lot of times looks like me, because it's that privilege piece that we talked about earlier. Same with eating disorders, right? When you think of eating disorders, like it's somebody who looks like me. Yes, absolutely. So we have to reconcile that and see, okay, do our own blind spots, do our own biases, does how we have seen the world, how does that impact how we're treating other people? So let's talk a little bit about language updates. And I think we can even update some of this. It's kind of up to you. So instead of saying abuser, junkie, addict, alcoholic, person with a substance misuse disorder, person with a substance use disorder, person experiencing an alcohol or drug problem, just a person or a patient, depending on your agency, a client, but just a person. That's what we are. Now, abuse, this is a tricky one because obviously, like, we have organizations that are like National Institute of Drug Abuse or the Substance Abuse and Mental Health, some of that. So some of this has come from SAMHSA, and I think they understand that their name is a little problematic, but that's a whole lot of branding that I don't know if they could do. But looking at, instead of abuse, saying misuse or harmful use, inappropriate use, hazardous use, problematic use, risky use, or just use, actually, because it can be a judgment. A lot of times, like when we say substance use, not calling anybody out, but if you have a glass of wine tonight, it's still substance use. I'm not saying that you have a problem at all, but it is substance use. So how do we not demonize that substance use and take away some of this like really unhelpful language? For drug screens, especially, not saying clean and dirty, this can be a really tricky one, especially if any of you work with the court systems. So saying something like negative, positive, or substance free, or maybe saying, if somebody does have a positive drug screen, is it positive for things it's supposed to be positive for? So I think oftentimes, like for people who are on Suboxone, if they have to do drug testing, like depending on the panels of drug testing, like it's going to pop positive for something, right? And so how do we have specific conversations around that? And instead of saying user, I'm referring to the use. Somebody said this earlier, like the person is first. Person first language is going to be so important. Therapeutic versus non-therapeutic, absolutely. So a person who misuses alcohol or drugs, a person who uses drugs, or if you're referring to the misuse, a person engaged in risky use of substances or behaviors. Now, remember that person first language, I'll get to AA in just a minute. Person first language does not apply to everything. So I'm specifically thinking of people who are autistic. A lot of people in the field, specifically who do that work, do not say, I am a person with autism. It's, I am autistic, because you can't separate the two. So I think it's really important to, when we're looking at how words matter, really making sure that we're not taking one approach and applying it universally, and we're just listening to folks. We're just listening. And then recovering addict. So this one I think can also be tricky, as many of us who are in the substance use field, many of us are in recovery, and we have our own recovery stories with this. I think when we are talking in general to somebody, saying something like a person in recovery, a person in long-term recovery from substance use, however that person identifies, as somebody mentioned, in certain meetings, you are asked to identify a certain way. Absolutely. If I am a person who goes to specific meetings, I might say, I'm Leslie and I'm an alcoholic. That is fine. You respect the house that you're in. However, I think if we look at, in the context of a professional presentation, as I said in the beginning, I'm a person in long-term recovery. So I think it's just really about being mindful. But if I'm sitting there working with a client, I'm not going to say, are you a recovering addict? Like that may not be how they identify. So I think being really mindful of the words, because especially if you're building rapport with somebody, that can absolutely torpedo that before you've even built it. Weight stigma. Okay, so when we look at weight stigma, I love this quote from Rebecca Puhle. She says, despite decades of science documenting weight stigma, its public health implications are widely ignored. Instead, obese persons are blamed for their weight, with common perceptions that weight stigmatization is justifiable and may motivate individuals to adopt healthier behaviors. I just saw somebody say, if shame and stigma worked, it'd be 40 pounds lighter. Many studies and researchers have linked quite the opposite. Weight stigma promotes harm, increased disordered eating behaviors, and lower levels of physical activity. It increases the risk for depression and body dissatisfaction, and an overall lower quality of care. With that, when we look at eating disorder stigma, I mentioned this earlier, anybody, any person of color, really, they are significantly less likely than white people to have been asked by a doctor about eating disorder symptoms. They're also BIPOC individuals with eating disorders are half as likely to be diagnosed or to receive treatment. A lot of times this has to do with assumptions about behaviors based on body size. This happens in general. So there are people who actually can be diagnosed as anorexic, or with something like, there is this term called atypical anorexia, which I don't love, because then it's also putting somebody in this box of, hey, you don't belong in the anorexia category, so we've put you in this atypical category. It all boils down to behaviors. I heard a person speak who has lived experience, who talked about how she was engaging in bulimic behaviors, so specifically vomiting, so specifically purging. And every time she went to the doctor, they would ask her about her weight loss techniques, because obviously, like, she needed to lose more weight. And she was saying, no, like, I'm actually not healthy. And then she switched to restriction, and that restriction was praised, right? And so how can we make sure, we'll talk about this a little bit more when we talk about like assessment and whatnot, how can we ensure that we are looking at things holistically and we're throwing out whatever our beliefs are about what that eating disorder is, what the behavior looks like? Again, dieting behaviors are often praised or endorsed when someone is in a larger body. Some of the most malnourished people that I've ever worked with are individuals in larger bodies. And I am specifically saying the phrase larger bodies, not because I don't think fat is a dirty word. I don't think it is. I think in the body positivity movement, there has been a lot of talk about not demonizing the word fat and ensuring that we are actually talking about it. I also know that as a person yes, take back fat, exactly. But I also know that as a person in a smaller body talking about fat, it can kind of be disconcerting. So wanted y'all to know that that's why I'm choosing to use that phrase instead. Let's talk a little bit about, actually, before we get into treatment, I would like to give us just a small 5-minute break so you can stretch your legs, go to the bathroom, all that different stuff. So then we can really dig into treatment approaches. So 5 minutes, like truly 5 minutes, and then I'm starting back up. So just going to take a quick 5. It's a good place to stop. All right, y'all. I'm back, guys. Friends. Sorry. Want to be inclusive. Back, friends. Everybody. Again, cheers if you've got your caffeine this morning. All right. Hope you enjoyed your stretch. There you go. Hope you enjoyed that. Probably need a little bit of water too. Don't forget to hydrate. Hydrate or dihydrate, y'all. Hydrate or dihydrate. Okay. So, revived hot tea. Oh, love that, y'all. Love that. It's such a gloomy day for some of us here. I'm located in Alabama, so I know we have some friends from all over, and it's pretty gloomy and cold. So, all right, let's dive back in, friends. Red Bull for the win. Oh, please hydrate. Please hydrate. I love gloomy days too, but not when they're super cold. Okay. Where I am in Birmingham. Bright and sunny. Okay, Florida. Ah, jealous. Jealous, jealous. Our friend in Maine up there it's pretty cold. All right, let's talk about treatment. Show offs. I love this. Okay. So when we look at treating substance use and eating disorders, really to be effective, they must be addressed simultaneously. Patients or clients, whatever you call them at wherever you're working, people are at a higher risk for relapse in both eating disorder symptoms and substance use disorder if not addressed concurrently while in treatment. So let's talk a little bit about assessment. I'll talk about this more in a few minutes, but looking at something called the EDEQ, the DAST-10, an ASAM, and then standardized assessments versus interviewing. I have a couple more on this next slide, but this is just kind of like a brief overview. And then when you do any sort of treatment planning and assessment, it should occur throughout the entire treatment process to ensure needs are being addressed. So residential versus PHP versus IOP versus outpatient. So for example, if I'm treating somebody, if I'm in a residential level of care, and I'm treating somebody who has substance use and an eating disorder, what we are going to talk about in terms of behavior containment, especially if we're looking at eating disorder and decreasing the eating disorder behavior, a lot of times if they're in residential, obviously there's no substance use occurring, right? And so with that, we need to address like what safeguards do we need to put in place before you get to PHP. And also let's look at what needs are being met by substance use. We'll get into that a little bit more. But that's an example of, okay, I'm addressing this in RTC. Then somebody goes to PHP and we say, okay, what supports can I put in place? What additional accountability can I have? What assignments can I look at? Like, what does it look like when you have so much time and you're typically using substances and now you feel activated? What do you do when activated? Versus IOP, versus outpatient. I'm going to go to the next one. Oh man, I need to go backwards. Okay. With assessment. So the EDEQ, it's the Eating Disorder Examination Questionnaire. This looks at a variety of behaviors and beliefs. This is used by a lot of treatment centers as an outcome measure. So a lot of times somebody may, if any of you work in treatment and you know that you have a client that does a lot of assessments at first and you want to be able to measure your outcomes throughout treatment, the EDEQ is a great one to start with, specifically as it looks at eating disorder behaviors. SCOFF is one that we'll talk about in the next slide, I believe. And it's actually more of a kind of user-friendly one that you could use in your outpatient setting if that feels appropriate. Or even if you are working substance use outpatient or even substance use residential, that might be a helpful one as well. As well as the CIA questionnaire. No, it's not that CIA. the Charlie India Alpha Agency, not that one. The Clinical Impairment Questionnaire. It's 16 specific questions looking at behaviors within the past 28 days. That's a pretty easy one as well. Then for substance use, we look at the DASS-10. That can be if you are not primary substance use, like if you're not working at a substance use facility, that is a really quick assessment tool that you can use that just gives you an indication that there could be an issue that you need to examine. The UNCOPE is also one, and we'll go through that. And then we have the ASAM, which is the American Society of Addiction Medicine. In Alabama, what we have is a placement assessment that is based on ASAM criteria. So there's many agencies that do that to get into any residential facility, really any facility in Alabama, whether it's residential or not, you need that specific placement assessment. And it's based on that criteria that ASAM has with 6 specific dimensions. And then there's also standardized assessments versus interviewing. So a lot of times, if you have a client who has to fill out like a biopsychosocial, some people will do it through an interview, and some people you just hand them the biopsychosocial and you ask them to complete it before their first appointment. That's fine. But sometimes the way that the questions are worded versus if you ask them and you kind of dig a little bit, you're going to get different responses. And we'll go into that a little more as well. So specifically the SCOFF questionnaire. So think of it like this. Do you make yourself vomit or sick before you feel, or excuse me, because you feel uncomfortably full? Do you worry that you have lost control over how much you eat? Have you recently lost more than 15 pounds in a 3-month period? Do you believe you are fat when others say you are thin? Would you say that food dominates your life? You give 1 point for every yes, and scoring 2 or higher indicates a likely case of anorexia or bulimia. Now, I look at this as this gives you an indication that there is something that needs to be looked at further, especially if you have a client, and many of us have experienced this, like, oh, that's not a problem. I'm fine. I'm fine. And we'll talk about this a little bit more too. How many of you have those? I'm fine. Nothing's wrong. Like they're that meme of that dog and the burning room. It's fine. It's fine. It may not be fine. Y'all know what I'm talking about. Every day. Yes. And then here's an example of the DASS-10 for those. Yes, denial is a powerful thing. DASS-10, maybe for those of you who are not familiar with this, these questions refer to the past 12 months. And there's, again, some of this language hasn't been updated, but I think it's still a good tool that you can use for any of your clients. So have you used drugs other than those required for medical reasons? That could be a tricky one, especially if somebody is prescribed something, but they're overusing their prescription. Denial. Don't even notice I'm lying. Wow. I love a catchphrase, and I love a slogan. Many of you who are on this training that know me know that, and I've never heard that one before. That Zach blew my mind. Okay. Do you abuse more than one drug at a time? Are you always able to stop using drugs when you want to? If you never use drugs, answer yes. Have you had blackouts or flashbacks as a result of drug use? Do you ever feel bad or guilty about your use? If you never use drugs, choose no. Does your spouse or parents ever complain about your involvement with drugs? Have you neglected your family because of your use? Have you engaged in illegal activities in order to obtain drugs? Have you ever experienced withdrawal symptoms, so felt sick when you stopped taking drugs? Have you had medical problems as a result of your drug use? So memory loss, memory loss, hepatitis, convulsions, bleeding, etc. I love this comment that just come in the chat. If you have an assessment tool, that's fantastic. If you have an assessment tool that still has some maybe like stigmatizing language, read it in a destigmatizing way, especially if you have a client or somebody that you're working with that you know it's not going to go well if they're reading kind of the stigmatizing stuff. So that's where I think in these circumstances, it's so great if you actually administer it and not just print the paper out and hand it to someone. So here's an interpretation of the scores. So there's, no problems reported, a low level, moderate level, substantial level, severe. And this is not diagnostic. It's telling you monitor or further investigation, intensive assessment needed. And so I think that, especially if you're working with someone who has a pretty strong level of denial, or is just not in tune, maybe like so pre-contemplation with some of this, I think it's really helpful that this says, especially if you tell them like, hey, we may need to look at this at a different time instead of like, you have a substance use disorder. I think that's going to land a lot better with this. The uncope, y'all, I love the uncope, just because I think it's so accessible. So have you continued to use alcohol or drugs longer than you intended? Have you ever neglected some of your usual responsibilities because of alcohol or drug use? Have you ever wanted to cut down or stop using alcohol or drugs but couldn't? Has your family, a friend, or anyone else ever told you they objected to your alcohol or drug use? Have you ever found yourself preoccupied with wanting to use alcohol or drugs? And have you ever used alcohol or drugs to relieve emotional discomfort, such as sadness, anger, or boredom? Again, this does not say definitively you have a problem with substances, but two or more positive responses indicate possible misuse or dependence and need for further assessment. Again, as somebody pointed out, if you have some words in there that are a little stigmatizing, you can kind of reframe on the spot. I'm thinking of how many of us who have done placement assessments in Alabama, the UNCOPE is usually part of some of like the demographic sheets. All right. Then earlier we talked about interview questions or potential statements. So if you are doing a first session with someone, or maybe it could be even down the road with someone, instead of saying something like, do you think you have a problem with drugs? First of all, if you say that, what is someone going to say? Put it in the chat. If you say, do you think you have a problem with drugs? Or do you think you're a drug addict? What are they going to say? No, no, nope, nope. I can stop whenever I want to. I can stop. Yeah, exactly, exactly. Of course not. No, no, definitely not. So even just saying, tell me about your substance use history. Such an open-ended statement. Tell me about your substance use history. And this next question, it's actually further down. But a good follow-up to that is when I say substances, I'm including prescription medication. I'm including over-the-counter substances. And so I think if you have this open-ended statement, it's coming off non-judgmentally and just saying like, tell me about your substance use history. Or even just say substance history, depending on the person, if that feels okay. I think, and you can just say, hey, I'm talking about everything. I'm talking about alcohol. I'm talking about prescription pills. I'm talking about weed. Tell me about your relationship with substances. Exactly, exactly. Tell me about your relationship. And again, as it kind of depends. It depends on what somebody is bringing into the room. It depends on some of the questions you already have set up, especially if you're at an agency. So tell me about your relationship or tell me more about substance use history, kind of depending on what it is that you need from that, I think is going to be helpful. I never buy it. Yep. I like that. Yes, I have heard that. And also asking, have you ever taken more than you intended? Just asking. Okay, tell me more about that. Tell me more about that, or help me understand, are some of my favorite tools in any kind of line of questioning, so to speak. Do you remember a time without any substances? What was happening? What was going on in your life where you felt like you didn't need substances? Tell me more about that. How is your substance use affecting your life, relationship goals? I think this also goes back into like, what is your relationship? Tell me more about your relationship with substances. And again, as I said earlier, when I say substances, I'm including XYZ. And so especially when I'm working with folks with eating disorders, I say, when I say substances, I'm also including laxatives. I'm including over-the-counter diet pills. I'm including things you can get at the gas station. That's what I'm talking about. Tell me about your relationship with your body. This can be a really uncomfortable question for a clinician if you don't know your own relationship with your body. This is where you have to make sure you're doing your own work too. Because with this, you never really know what answer you're going to get. Tell me your relationship with your body. There's can be trauma involved. There can be all about body image. It could be, I mean, you just never know. But I think one thing to remember is that you can ask that. The person who is sitting there with you should not determine if and how you ask that question. Like, it is okay to ask somebody in a larger body, tell me about your relationship with your body. It is okay to ask someone who is underweight, tell me about your relationship with your body. It's okay. It is okay for any of you, by the way, to go and see your therapist and say, hey, this person in this training told me that I should probably look at my relationship with my body. Go for it. You need to be in tune with that, because that also impacts how you show up in the room with a client, just as we talked about earlier with stigma. Growing up, what messages did you receive about food? Was there good food? Was there bad food? Healthy food? Unhealthy food? Tell me about your relationship with food. Yes, I also think that is a good one. That also can be a really scary one. So you have to, which, I mean, don't shy away from it. But I think you just have to discern if that is appropriate for that client at that time. Tell me about your relationship with food. Sometimes that shuts a conversation down. And kind of depending on the person, I might start off more with, what messages did you receive about food, especially if they're not as in tune with their own relationship. So this is really important. You know, I mentioned earlier that idea of the good food, bad food, need to earn food. I'm trying to be good. I'm trying to do that. Like, if we are saying that as clinicians, I just want to challenge that for all of you. I'm not saying that people, if you want to lose weight, okay. I think it is important to recognize where that comes from. Somebody has a question, what about children? I would love to answer this right now. Can you tell me more about that question? What do you mean, what about with children, Sarah? Like with wording the questions based on age. Okay. And their understanding. I think you could say like, sometimes with children, you can say, tell me what kind of food you eat in the house. Tell me what kind of food you have in the house. Especially if you're asking that question. Because sometimes they will just outwardly say, and my son has come home and he said something like, oh, I can't eat that. That's bad. And my husband was like, I'm gonna let you take that one. I said, what do you mean that's bad? And he said, well, I learned that in school. And I was like, well, let me tell you, this is what we talk about. And so I think like looking at food as fuel and how do we look at that differently? And just making sure they say like, hey, there are no good foods and no bad foods, but it's really important to eat like a well-balanced diet. So if you are or have a well-balanced lifestyle, I want to try not to use the word diet, but hey, it's okay to eat salads, it's okay to eat burgers. It's okay to drink water, it's okay to have juice. You just need to make sure that you have like a well-rounded idea of it. But asking, I think, especially young children, what kind of food do you have in the house? Um, what have you learned about food? That's another one for kids, especially. What have you learned about food? And that may not just come from parents, but from what they hear in school too. It's a great question, y'all. Food as fuel is definitely super helpful. And then something that may be helpful for you all, I have young children, and I in my house, like you eat whatever you want to, typically whenever you want to, but we'll have different conversations of, hey, um, this sugar gives you kind of like quick energy and it may disrupt your sleep. So maybe let's try to have this snack earlier in the day and not have it right now. And so let's try that again tomorrow. So having that conversation. Or when my son wants to just like eat all of the chocolate, I'll say, hey, maybe let's not have this piece of chocolate right now because it may make your stomach hurt and we'll have some more tomorrow. Yep. And sometimes, yes, sometimes that's true. Oh, diabetes is a whole, yes. It's a whole other. Mhm. Okay, I am not going to review the DSM criteria for substance use disorders, but I wanted to include this in here because if you don't have an assessment set up for assessing substance use, or maybe you don't typically treat clients with substance use disorders, this is a great way to do an assessment using the criteria. So, for example, I've had somebody who said like, "Oh, yeah, I don't have a problem with alcohol at all." And I'm like, "Okay, well, I'm just gonna ask you a couple questions. Have you ever taken a substance in larger amounts or over longer periods than was intended?" And so, and turning the criteria into a question. Have you ever had a desire or maybe an unsuccessful effort to cut down on your alcohol use? Like if that's what that person is saying. For those of you who are familiar with the ASAM or the placement assessment that's used in Alabama, these are your like Dimension 1 questions, right? And so you can take this specific criteria and you can turn it into a question. Yep, exactly. Okay. I do want to review the eating disorder criteria so that you all can get a better understanding of what we are looking at when we look at that criteria, especially because a lot of times people will say like, oh, well, you don't look like you have an eating disorder or whatever it may be. So with anorexia, it's the persistent restriction of energy intake leading to significantly low body weight. It can be one of the indicators, but doesn't necessarily have to be. Intense fear of gaining weight or persistent behavior that interferes with weight gain, disturbed body image, and the subtypes are binge purge type and restricting type. So binge purge, we talked about this before. There is a cycle of eating a significantly large amount of food and then purging afterwards. And then restricting is exactly what it sounds like, restricting caloric intake. With bulimia, it's recurrent episodes of binge eating, feeling a loss of control around food, objectively large amounts of food, and again with compensatory behaviors that we discussed earlier. So vomiting, laxative use, over-exercising, fasting. Fasting is a tricky one. I'm going to talk about that in just a moment. I'll finish this criteria and talk about fasting. Evaluation based on body size and weight. Binge eating and compensatory behavior occur on average at least once a week for 3 months. With fasting, it can be tricky. I saw somebody ask a question about religious or cultural differences. And so, there are some religions that during specific times you fast. And again, it's all about intent. I've had people that have met with their spiritual leaders that have said, their spiritual leaders have said, hey, in this circumstance, you do not need to fast while in treatment because and I'm using their language, your relationship with God, what's most important is that you are taking care of your body. So I think that is something to look at. And especially if there are specific foods that maybe are not eaten due to religious or cultural reasons, again, you check the intent around that. Is that food demonized, or is it, hey, I don't eat this food because it's not culturally appropriate? I have had clients who also have used their religion as a way to fuel the eating disorder too. So it, again, is all about intent. Same with veganism. There are people in eating disorder recovery who identify as vegans, who are ethical vegans. But again, it's all about the intent behind it. Okay. Binge eating disorder. So again, recurrent episodes of binge eating, objectively large amounts of food, sense of loss of control. Binge eating episodes are associated with 3 or more of the following. So eating much more rapidly than normal, eating until uncomfortably full, eating large amounts even when not hungry, eating alone based on embarrassment, feeling disgusted, depressed, ashamed after eating. It occurs at least once a month for 3 months, no compensatory behaviors. So with binge eating, you're not going to see the purging associated with it. Also, though, you can get into this like anorexia, excuse me, this like restrictive binging cycle as well. Okay. Fixing this for y'all. Hold on. A little more about ARFID. So ARFID is, yes, considered an eating disorder. It is treated very differently than we would anorexia, OSFED, bulimia, things like that, because this is more so about an eating or feeding disturbance and less about body image. So with ARFID, eating or feeding disturbance as manifested by persistent failure to meet appropriate nutritional needs. So there you're going to have significant weight loss, significant nutritional deficiency, a dependence on enteral feeding or nutritional supplements, a lot of safe foods, like maybe there's like 3 safe foods. You have to do like repeated food exposure because of this. Marked interference with psychosocial functioning, so not being able to eat different places because they don't offer certain things, not explained by lack of available food, and not attributed to a medical disorder. So a lot of times this is going to be related to if there's some sort of like texture issues, that's going to be at play. Other specified feeding or eating disorders, I mentioned this earlier, OSFED. So this was also called EDNOS a number of years ago. So with this, all criteria are met for anorexia, but weight is in the normal range. Or all criteria are met for bulimia, except frequency and duration. And so we talked about frequency and duration in the previous slides. Maybe regular purging after subjective binges in a person of normal body weight. Chewing and spitting is part of this. And orthorexia. Orthorexia is not technically in the DSM, but this is like extreme clean eating. I'm not going to eat any processed foods whatsoever. Somebody just mentioned pica. Pica actually is its own disorder. However, there are some people within their eating disorders, they have pica-like tendencies. And so I had a client who would eat cotton balls to fill up her stomach. So, but then she would also engage in like binge purge types and things like that. Exercise bulimia. Yep. So depending on the other symptoms, it could qualify as bulimia nervosa or as OSFED. It really depends on the other characteristics that somebody is displaying as well. So somebody asked earlier, I want to make sure I got this right, kind of the difference between anorexia and binge purge type. So the relationship is so like people with anorexia, with binge purge type, people with bulimia do that regular binge eating and purging over the once a week 3 month time frame, kind of like I mentioned earlier. But people with bulimia typically engage in both the binge and purge and not one or the other. And sometimes with anorexia binge purge type, it can be both, or it's one or the other. So you might have somebody who is just like they're purging everything that they eat. And because of the lack of binging with it, it would be more so associated with anorexia, binge purge type than with bulimia. Let's chat about some treatment modalities. So, cognitive behavioral therapy, many of us are familiar with that, gold standard in some respects. CBT can be really beneficial in the treatment of eating disorders, as well as DBT, especially if you look at things like mindfulness and emotional regulation. And then compassion-focused therapy, y'all, if you have not done any like research into compassion-focused therapy, please, please, please do so. I love it. It's about developing self-compassion in order to increase resiliency and decrease shame. It's incredible. So Kristen Neff has done a lot of work about self-compassion, and then Paul Gilbert has done work with compassion-focused therapy. There's so Alsana, which is a treatment center in Alabama, that is their preferred method of their preferred treatment modality is compassion-focused therapy. I think it's fantastic. And then last but certainly not least, motivational interviewing. If y'all, I think Alsana has done a couple of compassion-focused therapy webinars recently, and so you may be able to go to their site to look at it. Also, there's a ton of great stuff by Stan Steindl on YouTube. He has this series called Compassion in a T-shirt, I think. And so like little bite-sized snippets about compassion-focused therapy, but definitely Kristen Neff would be a good resource there. So motivational interviewing, we will talk about that a little bit more. Many of you are familiar with that. Let's talk about pathways of recovery. So a lot of us may say that we are open to multiple pathways of recovery, but we have to understand what that means. And so with folks, as we know, however they find recovery, whether it's through clinical means, non-clinical, self-managed, harm reduction, whatever it is, like just because somebody doesn't go to a support meeting doesn't mean that their recovery is any less. Just because somebody goes to treatment or has criminal involvement, like whatever it is, I think we have to just remember to be open to that, especially for individuals who may be don't have access to treatment. Just because they don't go to treatment doesn't negate their recovery journey in any way, especially when it comes to harm reduction. So when we look at different harm reduction measures, especially medications, so things like Antabuse or Camprol or Vivitrol or naltrexone, you know, all of these different things, it does not Suboxone, whatever it may be, any sort of medication-assisted recovery, having those medications involved does not negate anybody's recovery story. As well as there are people in recovery who maybe they are still using substances. Maybe it's they realize that they had a significant problem with cocaine and they can drink normally. It is not up to us to completely derail somebody's recovery story. I think it's up to us to challenge it in some way. This is the same with eating disorders. With eating disorders, harm reduction is really a preferred technique because when you think of it, if you tell an eating disorder client, hey, you need to stop purging, you've been purging 10 times a day, stop. Like that's not going to work. And so how can you say, hey, instead of 10 times a day, could we maybe try 8 times? Could we infuse some coping skills at different times? Let's look at this a little differently. So something for all of us to consider there. More about treatment, especially interventions within treatment, you want to examine the function of the behaviors. Right? So what are these behaviors doing? What are the benefits to the behavior? Sometimes when I ask a client, what's the benefit of this behavior? They say, oh, well, nothing. And I said, well, that's not true. If there wasn't a perceived benefit, then you would not continue to do it. So having them understand that, like, what is the perceived benefit? Creating a timeline of both the eating disorder and the substance use. You want to see maybe how they match up. And that I think also helps clarify maybe the relationship between the two. How does the substance use fuel the eating disorder behaviors and vice versa? So like, are they part of that? I'm thinking of like, the addictive system and the addictive cycle. So are those behaviors, how are they intertwined, especially when somebody is like in a using cycle? How do those behaviors relate to one another? Again, what needs do the behaviors meet? What you may notice is that the eating disorder meets specific needs that the substance use doesn't. And can we look at any type of overlap there? Behavior swapping is another thing to consider. So discussing the function of each behavior and the precipitating events that lead to behavior swapping, and then examining how you break out of those behavior swapping patterns. So what situations call for binging and purging rather than the cocaine use or like whatever it is, right? And so you want to really dig into that and figure out, I think, what the needs are. And sometimes it has to do with shame, where we switch back and forth because, okay, now this use, my alcohol use has really contributed to some downfall in my life. And so I'm going to stop that, but I need something to control. So I'm going to ramp up my eating disorder behaviors, right? And so looking at when those things happen, what are kind of the interruptions that we can put in place? What kind of resources, healthy coping skills or whatever, what can we put in place to interrupt those? And then another just a good example would be an empty chair exercise where the client can speak to their substance use and their eating disorder, or do it separately, however, allowing clients to put words to their struggles and increase that self-compassion. I think it's really important for clients to understand that when they're using these maladaptive behaviors, they're really just trying to do the best they can. And that's what they found that worked. These are behaviors that for some of them really like saved their lives in some way until they stopped working, right? And so I think that also that decreases the shame around the use as well. So can we normalize like, hey, everybody has something and you were doing this for a purpose, and this purpose is really no longer serving you, or this thing is really impacting your day-to-day life. So how do we do this differently? Let's talk about motivational interviewing. Some of this is a review for some of you, but I specifically wanted to do an overview of motivational interviewing and talking about how you can use it with substance use and eating disorders kind of together. I'm not going to get into all the wonderful nitty-gritty of motivational interviewing, but why do we use it? Guys, it's evidence-based. What we want to do is increase participant motivation, commitment, and action behind the key behavioral change components, increase the likelihood of compassionate action in daily life, can provide the opportunity for more buy-in and engagement, and promotes autonomy, specifically used to help elicit change. So these clients who are maybe more resistant to change, I think getting more buy-in for them. Motivational interviewing and compassion focused therapy go hand in hand. So many great links and relationships. So I would definitely look at both of them. If maybe this is the first time you've ever used motivational interviewing or heard of it, for some of you it's not, but let's just dig in some more. Okay, so remembering some basic components. So ORS, asking open-ended questions or statements, using affirmations, reflective listening, reflective statements, and summaries. So a reminder with our open-ended questions, what it's not, what is the problem? We're not going to say that, but saying instead, tell me what brings you here today. Not saying, how many years have you used drugs? But saying, tell me about your history of substance use. Tell me about your relationship with substances. Not how many years have you had an eating disorder? If you have somebody that comes in and they've reported to you, in an intake, you're in private practice and they check eating disorders on their box, and it's your first session, and you said, how many years have you had an eating disorder? Even if they said it, I don't know how that's going to land with them. Tell me about your relationship with food. Tell me about, I see on this that you've indicated maybe some past behaviors. So can you tell me more about that? Tell me more about. Put the ball in their court with that. Affirmations. I love a good affirmations, but many of our clients do not, because they think that affirmations are just, you're so great. And it's not. Sometimes it can be, I can do hard things, or there are other things that I'm good at instead of just whatever that internal tape is. So with affirmations, response to information provided by the client, identifying strengths, success and effort. I am worthy of recovery. Gosh, that's a beautiful one. I love that. Success and efforts to change. So not, wow, you're a strong person. Many of us are guilty of that as clinicians, but instead saying it took a lot of courage to share your eating disorder behaviors with me and come to ask for help, especially if they've just never mentioned it before. What we have to remember is that eating disorder behaviors are so normalized because of diet culture and how society looks at food, that a lot of times, like, people just think it's normal. And if they don't, or they have something that is really like rooted in shame, just being able to say, like, man, it took a lot of guts to say that, it took a lot of courage, or sometimes even an affirmation of, it depends on your style, but when a client tells me something really hard, I'm just like, God, that sucks. That sucks. I just want to like tell you that it's okay to not be okay. Absolutely. Reflective listening. Remembering with reflective listening, we are listening respectfully and actively to genuinely understand what the client is saying. helps build empathy, assists with the ability to paraphrase, discourages lecturing, validates clients' feelings. We want to avoid persuading the clients to agree with interviewers' opinions. So when we are really reflecting, we have to make sure that our own agenda is really like put in place. Because many of us, like, we just want to help, we just want to do, we just, all of these different things. And sometimes we just need to be there to bear witness, right? And so how we can do that. So different reflective statements that we can use. So with simple reflections. Ah, maybe I just invented a new word. With simple reflections, a basic restatement of what the client said. And then you've got your double-sided reflection. So reflecting the current statements, resistance statements, and previous contradictory statements that the client has made. And this is not to catch a client. That's not what we're interested in. But we want to point out the discrepancies. We want to say to them this example. So I heard you say that you recognize alcohol is an issue for you and you're concerned about drinking while you're in PHP level of care. I also heard you state that you're unwilling to go to sober living while continuing eating disorder treatment. Tell me more about what you're willing to do to support your sobriety while remaining in treatment. Tell me more about that. So then you're laying out that information for them. And still you're bearing witness to that. You can provide that feedback, but also saying, like, first you're saying this and you're saying this. And like, what is it that we can do together to help you meet your need and whatever that goal is? Again, with summaries, used to link or relate what clients have already expressed and then move on to another topic, expand discussion, or end a discussion. So here's another example. So far, you've shared with me that you've been using substances since you were 15 and are ready to address your use. I heard you say you will do anything to stop using. You also stated that you don't know how to be sober without using eating disorder behaviors, but are more concerned about dying from the eating disorder than drug use. So can we work together on a plan that can help you address both the substance use and eating disorder behaviors in a way that doesn't feel overwhelming? Now, that's not an open-ended one. So if that person says yes, or maybe you can say, let's work together on a plan that can help you address both. Or let's come up with some solutions. Let's come up with some interventions. So you've summarized everything that they've said. And that also gives them the opportunity. You could even say, like, did I have that right? Did I understand that correctly? And somebody can clarify or provide more information, whatever that may be. Another great tool to use is asking extremes. So what is the worst possible outcome if things continue to stay the same and not change? What's the worst that could happen? Especially with clients with anxiety. Tell me your worst case scenario. What happens in your brain? Or what is the best possible outcome if you change your behavior? Sometimes I'll ask, like, what is that? And then with that, if the worst possible thing, or what is the best possible thing, whichever, what is the fear attached to that? What does that feel like? Sometimes people are like, what? I'm talking about good things. There's no fear there. I'm like, okay, sure. I'm just putting that out there. So a lot of times there is fear attached to the good things. What would you look forward to most if you made the change? And so making sure that we are not just daydreaming about the future, but it's like, do we have some tangible goals that we can put in place? And then if this is the goal, what steps can we put in place in order to achieve that goal? What would you look forward to least if you did not change? What may continue to happen? This is another way of doing this is kind of playing the tape out. What happens if you do this? What happens if you don't do this? Right? How would things turn out for you in 3 years if you did not change? And how would they turn out if you did? And again, this is not a I'm going to be a millionaire and do all these things. I mean, for some people, it might be maybe like they have been mismanaging their money due to their substance use. Like, sure. But typically with some of the clients that we work with, it's not that. But it's like, how would things turn out in 3 years? Okay, if those are the things that you want, how do we get there? What is the work that we need to do today to get there? And if we don't do anything, what's going to continue to happen? Thinking of change talk, especially when we look at things like stages of change and how motivational interviewing is kind of entwined with all that. With change talk, the goal is not to convince a person to change. It's not, even though like we know that if they did some work and changed, it would be really beneficial for them. I know this. I know this. I'm also guilty of this. Um, it is to evoke the change talk that's relevant to the behavior. So we want to make sure that this is coming authentically from that client, from that individual, so that they have a better understanding of, we know what their buy-in is. We may not necessarily agree with it in that moment, but it is still, it's about where they are and less about our own agenda. We want to ensure that we avoid arguments, as it often becomes entrenched with the person arguing even more strongly against the change. So if you continue to push something, you're going to lose a client really quickly, right? Now, I'm not saying that we don't challenge. Challenging is very important. We all know this. Challenging is very, very important. And picking and choosing when that happens, right? Especially when it comes to if we get into that power struggle with a client, that dynamic, then we have to work on rupture and repair and all of that. The goal to gently guide the client towards the change talk, while at the same time ensuring that the client's arguments against the change, so the sustained talk, are accepted and validated. So we want to ensure that we're saying, yes, I hear that. And especially if there's discrepancies we can point out, that's where we can utilize them. So it's like, I hear you saying this. On one hand, you're telling me that you want to stop using alcohol. And on the other hand, you're also telling me that you're not willing to attend treatment, go to support meetings, take alcohol out of the house, like whatever it is. Can we determine together, like, let's come up with a plan that can help you support this goal if some of these other things are not, if you're not willing to do some of these other things, right? So how do we like gently do that? Gently also does not mean sugarcoat. I love this, the darn cat of change talk. If you don't remember anything else, remember, don't stigmatize people, and maybe remember a darn cat. Okay, so when it comes to change talk and darn cat, think about desire. So statements about preference for change. I want to, I would like to, I wish. So if you're hearing those statements from your client, or the individual you're working with, like you're hearing that there is that desire there. And so how do you kind of capitalize on that? Or maybe even if you're not hearing that, you can ask questions around that. We talked about this earlier with extremes, but you could say, what would you like to do if your anxiety wasn't hindering you from applying for school? What would you like to do if your depression didn't feel as big as it does? Then we look at ability. So statements about capability. I could, I can, I might be able to. Like, so we're inching towards that, not only the change talk, but the actual like movement around it. Reasons. So specific arguments for change. So this is going to come a lot of times from the individual, but we can prompt it. So I would probably feel better if I need to have more energy to play with my kids. Could be something. I need to. I would probably feel better. So if you say, you know, what would be different if you stopped using your eating disorder? What would feel different? And getting them to start recognizing, like, okay, are there things that I could do more of? Especially if somebody is saying, I feel tired all the time. I feel this is what, and we know this from substance use and just in general, that feeling of, on one hand, I feel this way, and on the other hand, I feel like I cannot give this behavior up, right? And so how can we start kind of developing those reasons or pointing them out? And then the need statements about feeling obliged or obligated to change. I ought to, I have to. Um, I would take should out of this. We know that should can be a really shaming word. So I think that is something for us to be mindful of, because as soon as a client says should, sometimes they go into that should shame spiral. We just have to be aware of that for sure. And then the cat talk of it, commitment. So statements about the willingness of change and to change. I am going to, I promise, I intend to. And then you can follow that up with, okay, so if somebody says, yeah, yes, you can should all over yourself. Yeah. I am going to, so let's say somebody says they have an issue with substances or an eating disorder, whatever. I am going to look up treatment providers tomorrow. Okay, great. Then we can look at what safeguards we put in place. Like, okay, after we look up treatment providers, like, is there a specific number of treatment providers you want to look up? Is there a specific area? And so asking some questions around that. And that can also kind of help with some accountability for them, but also provide support. Then actuation, so statements about their willingness to change. I'm ready to, I will start tomorrow, but not I will start tomorrow as a putting it off. So it's more so about like a commitment. And if they don't do that, that's okay. But that's a great thing to follow up in the next session. Taking steps, so statements about action taken. I actually went out to a meeting this weekend. This week I started journaling. This week I made an appointment with a dietitian and I attended it to get back on track with my meal plan. Right. And so a lot of this you are gently guiding, and there's a little bit of direction in there. But it's more so we're wanting to elicit that change talk from that individual instead of it being just our own agenda, which is really hard as helpers, right? We want to help people. Sometimes it's like, um, I want to know that if I tell you this is gonna work, and like I just want you to feel better. And it's like that, yeah, we can't always do that. We cannot always do that. So, oh my goodness. Here's my contact info. Use the Safe Project email because the other one, it may get lost. But Zach, we have a lot
Yes,
of
we have.
time questions.
Yes, we are getting to that point of our presentation, y'all, and you have had wonderful participation during the session.
Yeah.
Leslie's been great in being very responsive to the chat as we've been going. I would invite you to continue to use the chat
Mhm.
for our remainder of time together. If there's a particular question you have, we can also use the Q&A box as well. If you use the Q&A box, it has less likelihood it's going to be lost in the flutter of activity. So Leslie, a few questions that have come in. Some
Yeah.
of these are my questions because I'm interested too. You mentioned support groups a few times. So can you speak to how people can find resources for support groups? And also, you know, in coming from a substance use space, I'm very familiar with support groups with like AA,
Mhm.
NA, Celebrate Recovery, Self
Mhm.
Recovery, all these things. Can you maybe talk a little bit about comparing and contrast how support groups function for the eating disorder space?
Yeah, that's a great question. So there are 12-step based eating disorder groups. So there's things like EDA, which is Eating Disorder Anonymous. If I had thought of it, I have like they have a basic text essentially. I could have pulled them out for y'all. There's also a group called Anorexics and Bulimics Anonymous. There's also Overeaters Anonymous. I caution that one because sometimes, depending on the group, it teaches restriction. So I don't always go to that. That is the feedback that I have received from the people that I've worked with, that it has fueled the eating disorder instead of actually doing anything to disrupt the behaviors. And in Alabama, there's not many eating disorder awareness, or excuse me, eating disorder support groups that meet. There are a ton that meet online, whether it is a 12-step base or there's various treatment centers and nonprofits that hold meeting spaces. There is like MEDA, and which is MEDA, and there's some other agencies that will host online meal support as well. And so I think sometimes if you go into Google and you can put in meal support, I wish there was like an exhaustive list. There really isn't. But you could Google different meal support options. And then you can also look at Instagram. Actually, there's a lot of people that will do it via Instagram. They'll do some meal support. And any other local treatment centers. If you have an eating disorder treatment center near you, I would give them a call and ask them if they host an eating disorder support group. Many of them do.
Wonderful. Thank you for that.
Mhm.
So a trend that I notice, even anecdotally, is, and you spoke about it a little bit with the fasting.
Mhm,
And
mhm.
what I'm curious about is this a risk factor for those who might take fasting, and that moves into more of the eating disorder diagnosable category? And I don't know if there's been any literature about that, or maybe just things you've seen in your work,
Mhm.
because it does certainly seem eating disorder adjacent.
Yeah. So with fasting, especially things like intermittent fasting, it has to do with, are you getting proper nutrition in general? So there, I would have clients that were like, yeah, I did intermittent fasting, but they would be like, okay, so I can eat, I'm just making this up, y'all. I can eat from 11 a.m. to 7 p.m. and they would have like an apple and yogurt. But it was like, but I'm intermittent fasting. So it co-signed it. I think what you have to look at is, if you're doing something like that, to me, it is a co-signed eating disorder. And I also want to make sure that like it actually is beneficial for some people. You have to make sure, are you getting the appropriate caloric amount in that time period? So if you are not eating, if any of you are on a 1,200 calorie diet, that is not enough. It is not enough. That's like enough for like my toddler. Okay. Doesn't matter if you want weight loss or not. 1,200 calories is not sustainable. So you have to look at meeting your caloric needs, especially during that window, if you choose to do something like intermittent fasting. But things like intermittent fasting could also lead to binging later on, especially if you're only eating in a certain window. The rigidity is also concerning with that. So, again, a lot of it is about intent too.
Very good. And a couple of Q&As we have that I think maybe this, what you were just speaking to, can relate to, is orthorexia, and requesting a little bit more information about
Yeah.
that. And one commenter asking particularly what makes this problematic versus someone trying a quote healthier eating plan, um, in their words. So, orthorexia being this obsession that we're seeing with
Right.
healthy eating, and
Hmm.
those, but often can then lead to those associative restrictive behaviors.
Yeah.
So where do we find that balance, I guess, could be the word.
I think again, it has to do with intent. So if someone, let's say someone is on like this clean eating journey, okay, and they choose not to, like their friends are having a party and they choose to bring their own food to the party, that's a little bit of a red flag. Like if it's actually interrupting their daily lives, it's more so about demonizing the food. And here's the thing, whether you eat processed foods or unprocessed foods, like whatever it is, it's the value that is assigned to the food that is problematic. Um, there are some people who eat clean because it helps with migraines or helps with skin disorders or like things like that. And that is okay as long as it's not becoming so rigid that it's like, well, I'm at this party and I'm not going to eat anything because there's nothing I can eat. I hope that is helpful.
Helpful for me. We'll let the chat
Yeah.
indicate if there are follow-ups. I know a lot of our audience are in private practice. I know that because we often share a lot of the same audience over time, and that's kind of the feedback we get. Um, as I think about what that experience must be like of having someone walk into your office and is either telling you they have an eating disorder, or you uncover that through some initial assessments and orientation to what their needs are. I would feel in that position at a loss in many ways about exactly where to send them. And as we know
Right.
with anything with treatment, certainly I can refer to specialists, and I can work with trying to connect them with resources that I can find and we can find together. Um, but there's often then the reluctance for people to do that. And
Mhm.
so it's, well, I'm probably going to make decisions about continuing to work with them because, in my view, any
Yeah.
treatment's better than no treatment.
Right.
What would you say to that person in that position about maybe some things that they need to make sure they're considering or documenting, or in trying to help this person, but also making sure their bases are covered? Uh,
Yeah.
would that be potentially referring to primary care for health checks, or nutritionists, or fill in the, I mean, maybe those, but others that you might be able to tell us about?
Yeah, that's a great question. So I think so many different layers to that, right? I let's say, well, there's a couple of different things. Let's say someone comes to you and they are coming from treatment and they've decided like, hey, I've looked at your website. You don't specialize in eating disorders, but I think you're cool, like whatever it is, right? That's where it is really appropriate when you do an intake with that person saying, do you have a dietitian? Can you sign a release for that dietitian? Do you have a psychiatrist or a PCP? Can you sign a release? Will you sign a release for that person? Because then you want to make sure that you have this continuity of care. And I think that would be really beneficial. Now, the other thing too is if you have somebody who starts talking to you about various eating disorder behaviors, I think what you have to do is just be aware of your scope. Be aware of your scope, be aware of what you can provide versus what somebody else can provide. I have had people that have had two therapists. One completely specializes in eating disorders, and one is doing something else. And when they've done that, the therapists have releases and they talk to each other and they meet. That's not uncommon. I think the thing that I want everyone to remember is that one training does not mean that you are equipped to handle all eating disorders, and like continue to get training. Absolutely. Absolutely. I don't want you to be afraid of them either, but also understanding your scope and understanding sometimes like, hey, there may be a level where I will need to refer out, and that person then goes into like, oh, I'm too much, I'm too much. It's like, no, this is not my specialty. I care about you, and I want to make sure that you're meeting with somebody who can meet your needs. And so making sure that those recommendations come through.
Excellent. Thank you. Very good feedback. Uh, I think early on in the presentation, you certainly talked about the concurrent presentation of substance use
Mhm.
and eating disorders. Um, in the substance use space, we're often dealing with the phenomenon of cross addiction, kind of in air
Ah,
quotes.
yeah.
And so we're basically someone moving from one addiction to possibly one substance, but
Yeah.
maybe moving into a behavioral addiction. You know, you see a lot of people get out of drug and alcohol treatment, and uh, impulsivity with relationships and sex becomes
Yep.
much more in the forefront, or shopping, over shopping,
Yep.
overspending. Sometimes even, you know, we would put it sometimes in a pro-social category. You know, Freud would call it a sublimation defense
Yeah.
mechanism, where people get really into exercising.
Yes.
And, you know, friends and family are like, this is great because they're not using drugs and alcohol anymore and they look fabulous. You know,
Yeah.
just a little jest there, but it can quickly get out of hand. You know, it can
Mhm.
become its own problem. Now, so much of the things that the friends, family saw that were problematic are transferred to this behavior. Well, I used to never see him because he was drinking, drugging, and out with those behaviors. Now I never see him because he's in the gym all the time.
Exactly.
You know, so in eating disorder space, I imagine there's have to be so many similarities. Or do
Mhm.
you tend to see people moving in that cross addiction behavior to drugs and alcohol, or is it other behaviors? You know, you talked so much about control and how we're all trying to put control around the things in our
Mhm.
lives, and seeking that out as that source of dopamine and endorphins. So what are common behaviors that you're on the lookout for, maybe that you warn your clients about?
Um, Shopping is a big one. Y'all, when I worked in eating disorder treatment, the amount of packages we would get and the conversations we would have to have with people around that, as well as I think just, man, all of it. So it's hard. If you work primary substance, what happens is people have not been taking care of themselves for a while. They go to treatment and they gain weight because they've started eating food again. And then they freak out because they've gained weight and everybody goes on a diet and starts like exercising and getting the dopamine. I think having those questions of, hey, what is that doing for you? What is that doing for you? And so I'm just listening to what is somebody starting to mention a lot, or I'm asking like the questions of what does your relationship with exercise look like right now? Tell me about your relationship with exercise. Or have you noticed yourself getting lost in specific activities? If you are working with somebody pretty frequently, that you're going to see certain things, like especially if you're working in treatment, like you're going to know if somebody's getting like 15 packages a week and saying like, hey, what's what's happening there? Can we talk about that? Or even asking a question in private practice, like, what activities are you spending most of your time on right now? What would you say? What activities are you spending most of your time on? I'm
Very good
seeing
points.
a comment from Melanie.
Yes, I was going to call that out.
Yes,
You take it away.
absolutely. I think endocrinologist, absolutely. I think when we look at hormones, I think that's fantastic. I think that's fantastic information. I think we need to look at involving all medical professionals, and at the same time, we do also need to be aware that there's still a bias there, especially with weight. And so, be an advocate for yourself, especially if you know, like, hey, I don't feel right, and somebody says, we'll lose 10 pounds, like that. Mm-mm, mm-mm. Like, you need to make sure that you are actually like following up with what is happening for you and not just lose weight, and that will make things feel better. I saw something, examples of self-compassion behaviors. um what I would tell clients is like eating is a self-compassion behavior. Allowing yourself to nourish, to hydrate. um I think there is a lot of different affirmations you can practice with self-compassion. And some things I saw these beautiful affirmations that came up at different times of like, I don't have to be perfect, or I don't have to be good at everything. My value comes from who I am, not what I do. I think that is a really important one. Self-compassion also looks at forgiveness for self at times, not necessarily forgiveness for others. But I think that some of that is just an understanding of the things that I did or the behaviors that I used. It was really a way to protect myself. And how can I like shed some of that shame with that recognition and understanding?
Right. We have a question in the Q&A specifically about Adderall use for weight management and prevalence. I can tell by the look you just gave a little bit, this is pretty prevalent, or at least it's an area of consideration and concern.
It's an area of concern and it's twofold. So one, people are prescribing it for weight management, and it's an appetite suppressant. So like, that's not really, I think that's not really helpful. The other thing that we're seeing is that even within the eating disorder treatment field, people are prescribing things like Adderall and Vyvanse, specifically for binge eating disorder, because it helps with some of the compulsivity. I struggle with that a lot. I struggle with that because one, does it actually reinforce that like, hey, you should be in a smaller body? Like, does it actually reinforce some fat phobia by giving somebody this medication? But I also have had people that have been on things like Adderall, Vyvanse, even Ozempic or other like GLP-1s that have said like, hey, this has been really helpful. It's all about, again, the follow-up and intent. I think that's where,
Since you mentioned Ozempic,
yeah,
I'd like to go there. We've had a couple people in the chat. I know that this is an area that can be fraught with minefields and
yes,
opinions, and lots of people have had experiences with
yeah,
these medications,
yeah,
positive, negative,
yeah,
full spectrum, right?
yeah.
Ozempic in particular is of interest in this cross section of us talking about substance use and eating disorders, because not only is it being hailed as a silver bullet in weight control,
Mhm,
but it also is having some indications of helping with cravings of alcohol and other substances.
mhm, mhm.
So what can you tell us about that, and knowing that this is all very novel, and we're still uncovering a lot of information about it?
Um, I I think you kind of just answered the question because we're still uncovering a lot of information about it. Here's the thing, GLP-1s are absolutely helping people when it's used appropriately. Absolutely when it's used appropriately. I think when people are just like getting Ozempic, um, because like they want to lose like 5 pounds, like that just doesn't feel appropriate. And especially when there's such a surge of use that it's actually not available for the people who need it. Like I think that is concerning. Now, any sort of like GLP-1 that is used or something like Ozempic, if there is some like underlying body image, relationship with food, things like that, they're there. I think that needs to be worked on with medical providers as well. Like we can't just use the medication and not work on the other stuff that fuels it, because then we're looking at potential cross addiction and whatnot. Now, I have seen that they are starting to like really study it for alcohol use and for drug use. I'm not there with it yet because I'm a little concerned that we could also get into this space of we're prescribing something and there's no follow-up with it. Like that is the thing that I'm always concerned about, is when somebody's just given something and there's no follow-up to it, or there's no like intentional treatment with it. I would love to see the studies, especially with the GLP-1s. The other thing too is if you're giving it to somebody for substance use and they start losing a lot of weight and they have underlying eating disorder stuff, so to speak, like, is that actually being treated, or is it being co-signed because of the weight loss? Like, again, it's all about intent, and it's all about having healthcare providers around you that can be attuned to some of that, and not just, you know, you lost weight, this is great. But it could be beneficial for sure.
The way you speak of it sounds a lot like how we talk about MAT or MOUD as it's being
Exactly.
called now. It's a tool of the trade, but unless we're working on the underlying problems,
Yeah.
the medication can only go so far.
Yeah. And I think the other thing with like different GLP-1s, I think it's specifically Ozempic, but there's some of them that have some like really, for some folks, some really severe side effects, like with like essentially like stomach freezing in a way, like and some gastrointestinal issues. So I think again, just like making sure you're in tuned with all of that and talking to your providers. And if you are noticing, hey, I am using this medication and I am having certain thoughts and feelings coming up with it, are you talking to a therapist about it? Are you talking to a provider about it? Or as the therapist, and that person says, hey, I'm on Ozempic, and say like, hey, like what's happening for you around that? Just like asking how that's going. Much like, a therapist would ask somebody like, hey, I know you restarted your Lexapro. How are you feeling on that? Right? Like we would ask that question. I think just being in tune with that too.
Fabulous. Really, a good question I see here in the
Mhm.
Q&A, and I had not thought about this, and I've thought about this a lot with substance use disorder, but it's the impact of COVID. We
Mhm.
know that during COVID, substance use rates increased,
Mhm.
especially among certain drugs. Alcohol rates went high for a lot of reasons. Other opiate use disorder increased. That's why we continue to see the overdose rates we are today. Um, what in terms of what we were seeing in eating disorders, did COVID propel any of that? Did it throw gasoline on the fire for a lot of
Yes.
people? Because it was a time
Yes.
of isolation.
Yes. It was a time of isolation. So eating disorder behaviors increased. And then, especially for college age students, um, their families were more in tune to their eating disorder behaviors because they were with them. And then again, like it was a sense of control. And so what we saw in the eating disorder treatment industry was like a boom, because also people had the ability to go to treatment. More so because a lot of people were working remotely. And so it was like a little bit easier. Access is always still an issue, but we saw like a surge of eating disorder treatment. And now the need is still out there, but the ability to go to treatment has dramatically decreased because as we've seen, everybody is like, okay, we're no longer, not everybody, that's a generalization, but a lot of people are like, hey, we're not working remotely anymore, we're going back to the office. And so it's really cut off access. There are a number of good virtual eating disorder providers. So like within health, Equip, which just expanded to adult access. They primarily were like adolescents and under 18. Alsana has some virtual treatment. Other places have virtual treatment as well. And I think that has become more accessible for folks. But yeah, we definitely saw an increase in eating disorder patients. I did see a question come up about individuals who have low socioeconomic status in regard to seeking eating disorder treatment. So the answer I'm about to give, I don't love, because in Alabama, we have this system, uh, whether, it's very imperfect, but the substance use treatment system where we have state funded treatment. We have state funded treatment for substance use disorders. We do not have that for eating disorders. Anytime somebody has to go to eating disorder treatment, it's usually private pay, insurance based, or they're scholarshiped in. Now, there are a couple of organizations who will have scholarships. Um, they're not always posted. They're not always like advertised. There's also some organizations that will help fund treatment. So Project Heal, which is, if y'all do not follow Project Heal, they're a fantastic organization, and they have something called their Healers Circle. And it's like a network of providers who have committed to either providing reduced or free treatment for certain number of sessions, like across the country. So that's something to look at. Project Heal will also like help fund different things. There may be other states that have a kind of like state funded eating disorder network. If they do, I honestly don't know of them. I wish that I did. But I don't love my answer for you on that, honestly.
Understood. Could you speak
Yeah.
about intuitive eating is another question we've had come in the
Intuitive eating is great. Intuitive eating is fantastic. It's utilized in treatment. It's utilized in treatment. However, you cannot expect someone to engage in intuitive eating who has been restricting for 20 years. So it's like it's a gradual step. Intuitive eating, if you have not purchased the book or seen the book, it's by Evelyn Tribole, I believe. There's a couple different iterations of it. It's fantastic. But that is a step in the recovery journey. You can't always go from I'm restricting and purging multiple times a day to intuitive eating the next day. So I think you can start like weaving in the principles of intuitive eating. What we have seen in treatment is that typically when people are in IOP and they've had like a good length of treatment, we've had like a significant decrease in behaviors, and we really dug into relationship with food. Then we're really in PHP, maybe end of PHP into IOP. We are looking at intuitive eating and how we incorporate those principles.
Great. An intervention that I was told about, in probably grad school in this space was food diaries. And what I read now is that there are pros and cons to food diaries.
Yeah.
Could you speak to some of that? And maybe this fits in with pivoting people more towards intuitive eating and other topics you've given more praise for.
Yeah, so food diaries, that's a tricky one as well, because they can be beneficial for folks, especially if they have not been sticking to any type of meal plan. So that's something where if I have a client who's also working with a dietitian and we're looking at like meal plan adherence to like really get some like well-rounded nutrition, I may use something like Recovery Record or an app that can help. Like we used an app where somebody would take a picture of their food before and after, and then we would process it. And we would ask them like, what came up for you during this meal? Like what prevented you from moving forward on like the carbs or starches or whatever it was. And I think like that can be something that's beneficial. I would rather do pictures than like a diary, so to speak. But especially if somebody has a meal plan, like it's a good piece of accountability if they're willing to participate in it. Oh, somebody just asked about clarifying acronyms. Absolutely. So PHP, IOP, absolutely. So PHP is partial hospitalization program. And the hours for substance use PHP and eating disorder PHP differ. So for substance use, it could be, 6 or 8 hours a day, for where you're going into programming and then you're leaving the facility, whether you're staying at like facility sponsored housing or maybe sober living or something like that. And usually it's between 6 and 10 hours a day for eating disorder treatment. It just depends on somebody's needs. And then IOP is intensive outpatient. So that is a shorter duration of time during the day. It could be 3 hours, 4 hours, something like that, 5 days a week, 3 days a week, just depends on the person's need. And again, they're not staying at a facility where you would if you were in residential, but you can go, you have treatment, then you leave, you practice your skills.
Fantastic.
Sorry, I have one last thing.
Do one more.
I hate diet apps. I saw that. But somebody asked about the use of the word clean when talking about clean eating. I think clean eating is one of those words that, or that term that everybody is using right now. It may be beneficial to look at it as like processed and unprocessed foods. I think like clean is a judgment word, absolutely. But I think when we are discussing like behaviors, it's okay. Like if you're saying like, hey, if somebody says, oh, I'm eating clean, I would say, what does that mean to you? Like, tell me more about that.
Excellent.
Yeah.
I'm noting the time. And we are getting right at the end. Let me give a couple more announcements for folks. Leslie, thank you so much for the information. I think we could continue to talk all
Yeah.
day, and I think we have the interest for it, which is great to see. We will be closing up the session here in just a minute. We have put the survey link for the chat, survey link for the evaluation in the chat a few times. We'll probably post it a couple more times as I'm talking. We have some information on the screen now about how to get in contact with Bradford Health Services in particular for free consultations for substance use disorder treatment. Please be on the lookout. If you don't want to grab the link from the chat right now, be on the lookout for your email. It's going to include resources from today's presentation, copy the slides, link to the recording so you can access it again. You can only get continuing education credit if you watched this live and you complete the evaluation. Remember, you got 30 days to do an evaluation. After that, we close it. Not going to be able to do them from that point forward, so you will not get credit. Go ahead and knock it out as soon as possible, friends. It's going to come to you today. You can grab it. You can be done with it in 2 minutes and get it off your to-do list. Please go ahead and get her done. Please check us out for future topics. Join us on social media. Check out our events page, bradfordhealth.com/events. That's where we post all of our upcoming webinars. We will be doing ethics again in June. Please come and join us just in time for everybody's renewal cycle to get your hours in. That's why we do it in June. That will be posted up in the next probably month or so. You'll be able to register for that. Again, for Leslie to reach her, check out Safe Project. You can Google that. There's also information in the slides that you'll be getting a copy of. Please look at that organization. Keep it in your resource Rolodex for when you are working with clients who are needing eating disorder treatment resources. Leslie, any final words from you today before we close out? Again, I appreciate your time so much today.
No, thank you so much. I just appreciate everybody's participation. This has been a beautiful way to end my week. So thank you all so much. I just appreciate you. And if you all need anything, we'll send the slides out and you'll know how to reach me.
Absolutely. Thank you all so much. Take care.
Thanks.